large majority of the patients are transferred using helicopters, but in low-income countries like ours, a lot of this transfer happens because of taxis, private cars, so we need to understand whether we are doing enough or not. So I'll welcome Dr. Tanu Jain, who will be chairing our session. She's the Deputy Director General of Health Services of the Ministry of Health and Family Welfare. So we'll start this session with a talk by Dr. Ian Roberts. He's a professor of epidemiology at the London School of Hygiene and Tropical Medicine.
I want to talk about tranexamic acid for trauma victims. And the reason I want to talk about it is that it's the only proven effective treatment for trauma patients that exists, to the best of my knowledge, and most patients in most places don't get it. And they should. And so I'm going to tell you the evidence for this intervention. So this was an article in the Times about a year ago. Accident victims could be saved in minutes with one simple injection, and it's true. There's nothing about this article that is misleading. One simple injection can cut deaths due to bleeding by a third. And so the background to this is that there is this medicine called tranexamic acid. It's often known as TXA because it's easier to say. And it's been used by surgeons for a long time because it clearly reduces surgical bleeding. If you give a dose of tranexamic acid just before surgery, it cuts blood loss by a quarter and cuts the need for blood transfusion by a quarter. And we know from very large trials, over 100,000 randomized participants, that it doesn't seem to cause thrombotic side effects. So this is all very nice. So tranexamic acid safely reduces surgical bleeding. A recent trial published in the New England Medical Journal, it was only a few months ago. Again, there's been lots of trials, but this is one of the best. Highly significant reduction in major bleeding and no increase in vascular occlusive events. So it's good. It works in surgery. Now, how does it work? It stops blood clots from breaking down. So whenever a blood vessel is ruptured and starts to bleed, the body responds by making a fibrin blood clot. But there's also an enzyme in the blood that breaks the blood clot down, and this worsens the bleeding. And tranexamic acid inhibits this enzyme-induced blood clot breakdown. Now, traumatic and surgical bleeding are really similar. Your body doesn't know whether you've been cut open by a surgeon or a villain in a back street. The physiological response is the same. The physiological response to the bleeding you get after a car crash is also just the same. So because this drug clearly worked in trauma, in surgery, we wondered if it can work with trauma. And so we did a big randomized trial. It was a big global trial called the CRUSH 2 trial. We recruited thousands of patients from hospitals from countries all around the world, including India. We had lots of patients recruited in India, and we got this great result. Tranexamic acid reduced bleeding deaths and all-cause mortality with no increase in thrombotic adverse events. Now, the treatment effect was really strong and really big, but the treatment was most effective when you give the drug within an hour of the injury. So when you give the drug within an hour of the injury, there's pretty much a 1/3 reduction in death due to bleeding. So a really big effect, but you have to give it early. And of course you have to give it early because it works by preventing bleeding, and bleeding occurs from the moment of impact. So you've got to give it early if you want to prevent the bleeding. And a 1/3 reduction is big. So after the Crash 2 trial, I had to go and talk to some, I don't know, US military doctors because people were dying in Afghanistan and Iraq, and they were interested in this drug. So I went to Arlington Cemetery and I photographed this hillside of graves. These are graves of soldiers who died in Iraq and Afghanistan. And there's just 100 graves in this picture. And I photoshopped a 1/3 reduction. And there aren't many people who would disagree that that's quite a significant reduction. So you don't need significance tests or anything. A 1/3 reduction in death due to bleeding is big. After the trial, we worked out how many lives could be saved in different countries around the world if trauma patients received tranexamic acid. And the most benefit would be India and China because of the large populations and the high, mainly the large populations, but the fact that road traffic crashes is a major public health problem in both settings. Also big problems in the United States and Brazil. In the United States, because they think it's a constitutional right to shoot each other. In Brazil, because they've got a combination of car crashes and violence, and similarly in Russia. But India and China are where most, where there would be a big impact. On the basis of the Crash 2 trial, tranexamic acid went into pre-hospital care guidelines in the UK, but I'm not sure why, but they said patients with isolated traumatic brain injury should be excluded. So we did another big trial, this time the Crash 3 trial, tranexamic acid in isolated traumatic brain injury. And the effects were the same as in the Crash 2 trial. So it doesn't really make any difference whether it's head and body, just head alone. Tranexamic acid saves lives regardless. And there have been a few other trials in the United States, much smaller trials, but they pretty much confirmed the results of the Crash 2 and Crash 3 trials. So the confidence intervals are really wide and they didn't get statistically significant benefits, but you can see that the treatment effect estimates are pretty much in line with what we found in the Crash 2 and Crash 3 trials. Now, the critical thing for this discussion is, this is a discussion about pre-hospital care, and tranexamic acid really has to be given early. It has to be given within an hour of the injury, and there's actually a 10% reduction in the survival benefit with tranexamic acid with every 15 minutes delay. And that means it's a pre-hospital drug. It has to be given by paramedics at the scene. Now, paramedics in the Crash 2 and the Crash 3 trials, we gave it by intravenous injection, but we've subsequently done research that shows that it's well tolerated and rapidly absorbed after an intramuscular injection. So just like the Times article said, a single intramuscular injection of tranexamic acid after injury saves lives. And this is the only proven safe and effective treatment for trauma victims. It's kind of like a vaccination for serious bleeding. You can give it to a wide range of trauma patients. You can't really get it wrong, because if you give it to someone who doesn't need it, they won't get any adverse effects because it's a very innocuous drug. But if in a bleeding trauma patient, it's life-saving. So that's all I want to say. Tranexamic acid is the only proven life-saving trauma treatment. It's a cheap generic drug that's produced by many different countries, many different companies in India. In fact, some of the largest generic manufacturers are in India. Nevertheless, most patients don't get it. I think they don't get it because it's a cheap generic drug. And so there's no big push by, there's no big nobody's making a lot of money out of it. That's the main problem with this drug. Patients don't receive it. We need to fix this. Thank you very much for listening.
Dr. Roberts, it was a very good demonstration of the random control trial and its effectiveness in the trauma patients. I just want to understand one column in your results. What is the placebo there that has been used, which is not showing effective result? Thank you.
Yes, it was a placebo-controlled trial. So the CRASH-2 trial, we randomly allocated 20,000 patients, 10,000 patients got tranexamic acid, 10,000 patients got placebo. And there was a big difference between those who got tranexamic acid and placebo. So the two groups were the same, except one got tranexamic acid, one got placebo. And if you got tranexamic acid, you were a third less likely to die. So die from bleeding, and about 15% less likely to die overall. So it's a, you know, it's, I'm sure about the results. The main challenge is implementation.
Hi, and this is Professor Amit Gupta. I am Professor of Trauma Surgery at the All India Institute of Medical Sciences. And we were a part of the CRASH-2 trial also, as you know, the AIMS. Just a word, if you can throw some light on the patch trial and the preliminary result of the pre-hospital administration of tranexamic acid. I think there were about 15 centers, including UK, US, Australia. Any light on that?
Yes, the patch trial, I think, unfortunately, will make relatively little contribution to our understanding of the benefits of tranexamic acid because it's quite small. So there's been about 30,000, the CRASH-2 and CRASH-3 trials include about 30,000 patients. The patch trial's got about 1,200 in it. I think the premise of the patch trial was a bit dubious. The premise of the trial is that, well, we did the CRASH-2 and CRASH-3 trials in high, middle, and low-income countries. Do the results apply to people in Australia who have got high-tech trauma care? I think that's a silly question in a way, because we all bleed the same. We're all human. Our coagulation system doesn't really give a damn whether we're in India or in London. So our physiological response to bleeding is the same. The effect of tranexamic acid is the same. And we showed this. We showed that the effect of tranexamic acid, there was the same proportionate reduction on 4 continents. And it was the same in India, Africa, Latin America, and the Caribbean, Europe. And so the idea that it would be different in Australia, I think, is a bit silly. But anyway, the patch trial is going to come along. I predict a non-significant benefit, and that the authors, but when it's added to a meta-analysis, it will, whatever it shows, it can't change the results because the current results are too big and stable. So it'll be of some interest, but not much, I believe.
Just a second. Okay. Thank you, and that was an excellent presentation. I am Dr. Tanu Jain, and I am heading the trauma program in the country. And I am aware of this. I think there was a discussion, 3 years back when we were doing the state road transport ambulance systems, and we were looking at what essential items should be there in the ambulance. So tranexamic acid was mentioned. I just need to understand from you, while you were doing this study in India, who administered this particular injection? Which was the person? Like, it was done in the pre-hospital setup in the ambulance or in the hospital? And was the paramedic responsible for giving this injection, the tranexamic acid? Thank you. Am I clear? Could you get that, or I should repeat that?
I think I got it. I wasn't sure what the question, but basically I heard that it was incorporated into the list of medicines that should be provided pre-hospital. Yeah. But it's a bit the same as the UK, really. It's in pre-hospital guidelines, but often patients don't get it. Yeah. And they weren't getting it in the UK because the paramedics didn't like giving an intravenous injection. They had to do a cannulation and everything. But now it can be given by intramuscular injection, and that really greatly simplifies it. And so, you know, in the future, I think companies are now developing tranexamic acid auto-injectors. So it could even be given by a police officer who attends the scene. Police officers often attend the scene first. And so if a police officer had a tranexamic acid auto-injector in their pocket, they could easily administer this drug to a trauma victim.
Okay, thank you so much.
Yeah, thank you. See, is that something like EpiPen that you plan?
Yes, I'm here.
No. People were asking, will it be like pre-filled syringes or like a EpiPen sort of a thing?
I think it could be all of the above. I think very sophisticated ambulances might like pre-filled. So the military are very interested in rather sort of more expensive auto-injectors for use on the battlefield. And those will be strong and robust and easy to use, but they'll be a bit more expensive. I think for the big civilian market, I think pre-filled syringes is probably the best balance between cost and simplicity. So I think your suggestion is a very good one.
Thank you. Thank you so much, Ian. Thank you for joining us despite your meeting schedule. Thank you so much.
Thank you.
Dr. Mathew Gupta, shall we start?
Thank you, Rahul. Thank you, Professor Geetam, and thank you, Dr. Mathew. Very quickly, I'll go through, because the session was on pre-hospital care. So later on, I was told that how trauma centers function should also be incorporated. So I have tried to dovetail both the presentations, and the title I have changed to how pre-hospital care can be dovetailed into the definitive care. Well, obviously, we all know what pre-hospital care looks like in India, but I just want to, once again hammer it out and tell about it, what it is there, and what are the possible thought processes which can probably go into it. So I don't have any things to hide. Well, the objective would be just to, sort of tell you very broadly about the pre-hospital care right now in India, and then just a few questions on the way to get forward or to look forward, so that we can generate some sort of a debate. So pre-hospital care, as Rahul said, is just nothing but immediate availability of basic life support and rapid transport to the best possible facility. In a nutshell, it means that, called various things at various places: EMS, pre-hospital care, ambulance services, first aid squad, rescue squad, what all. The all emergency approach is one of the best approaches, because we cannot segregate trauma ambulances from any other ambulances. So worldwide, mostly all the ambulances would take care of all the patients, whether trauma, which we are talking about today, or it be a heart attack, or it be any other emergency. This is the international best practice model. We just can have it as a reference model and discuss about it, but obviously to reach that level, we'll take some time. We are struggling with the universal emergency access number till now. Leave aside the so-called control room and to and fro of the messaging about the patient care. Well, just a look back, it's been now approximately 38 years of organized ambulance services in India. Fortunately or unfortunately, it started with Delhi in 1984. That's what I could find from the net and from the literature. It was known as CATS. It's still known as CATS, the Centralized Accident and Trauma Services, although it ferries other patients also. There are two numbers right now. Even for CATS, there are two numbers, 1099 and 102. Thereafter, Bangalore, then Hyderabad had their own. They were mostly urban based. Till the time probably the landmark was when it opened in Andhra as a PPP model in 2005. And that pretty much changed most of the pre-hospital care in most of the states, because more and more states were going in for this PPP model, tendering their ambulance services to private partners and then paying the stuff. It's good, but it's got its own problems, and I'll just tell you. I just want to show you, this is our trauma center, this is the porch, this is generally how the patients are brought in. You can see a police van, there are no protective equipment there, the patients are being just, this is just in front of the trauma center. This is again variable ambulances. You'll see all types of vehicles being used as patient transport vehicles. Again, no neck protection there. These are private vehicles. You can see many of the patients are actually brought by their private cars from far away. Then auto rickshaws, those who can walk, walking wounded, or somebody who can walk. Again, just to highlight that these are variable types of ambulances, still no particular type is assigned, although the government is doing bit. But most of them are brought by the police. Unfortunate, but yes, semi-trained or untrained people in the police force. And this is what happens on our highways. Now, there's no way for this ambulance, which is standing there, to go. The traffic is there. So various problems. These are practical photographs, real photographs, or real films from our place. Anyway, so this is something from our trauma center, a level 1 trauma center, Delhi being the national capital region. And you can see the data is of more than 55,000 patients. Most of these patients are the vehicles used are police vans or auto rickshaws or private ambulances, no centralized ambulance services, private four-wheelers, motorized two-wheelers also. If they can sit on the back, then injured patients are brought by any vehicle which is there, which is the nearest. Who brings the trauma, these injured patients? Well, family and relatives, most of all, bystanders, police. A large number of patients are being brought by police. And you can see year after year, the CATs, the percentage of patients being brought by CATs is just about under 5%, not more than that. So variability of these ambulances, structures. In 2018, the Government of India, Ministry of Health did have this, and along with the Ministry of Road Transport and Highways, did bring about the National Ambulance Code. How much it is being followed, I don't know, but yes, definitely this is drafted by the central government. It's just a code for how the ambulances or ambulance infrastructure should be. So it's been divided into a first responder, a patient transport vehicle, a BLS or a basic life support, or a road sort of advanced life support, which is type D. Then air EMS was just told by Rahul, yes, it is there. It is not that we don't ferry patients by air, but primarily it is propelled by the corporate sector, generally for interfacility transfers, also propelled by a lot of medical tourism, I would say. And then it is extremely expensive, and it is generally self-funded. So it's not found its way into the common parlance for accident victims till now. Well, multiple ambulances, as I said, multiple sources of ambulances present on in the same region, belonging to various hospitals, NGOs, trusts, and private ambulance services. Yes, as I said, this was the experiment we started in the Andhra Pradesh in 2005. The 108 ambulance services on a PPP model. They have a common number for all the emergencies, police, fire, and ambulance services, which is good. They have a call center, and the call center would then direct the ambulances which are nearest. They have a GPS, GPRS system also. But the main problem with them is that there is no legislation or EMS body which is auditing them on a regular basis in the state. There are low salaries, there's a very high attrition rate of these ambulance personnel. They would not stay there because their salaries are not akin to what they do. Then the paramedic training, who is manning those ambulances, what is their level of training? Again, the issue of sustainability of such an ambulance service. EMS manpower, again, the national guidelines on pre-hospital care, I could gather, again, drafted by the Ministry of Health and Family Welfare. Who can be EMTs? A lot of heterogeneity there also. The private ambulance, 108 ambulance services are given the leeway that they will just train them for about 2 to 4 months, variable periods, and then these people can work on the ambulances. But then there is a 9-month certification course in Delhi in various hospitals, 3 or 4 hospitals, which is running. And these people are generally graduates or 10+2 in science, and they get trained for another 9 months. Again, a lot of variability there. Just what's the way forward? Probably we need to think, advocate, and implement certain things which come to my mind offhand are: one, access to emergency care. We need to seriously, once again, look into the universal emergency number. Although the MORTH has declared some number, 1031 or 21, I don't know, as the common number, but still if you go on the highway, you would have different banners every 50 kilometers with 10-digit numbers there, which the concessionaire who's running the highway made that these are the emergency numbers. It's impossible to remember them, and it creates a lot of confusion. Secondly, whatever ambulance services we have, we need to do both structural and functional audits of them. We need to have an audit cycle. We need to sit back and see whether or not these ambulance services, whether provided by the NHAI or provided by the 108 ambulance services, are functioning properly. Third, we need to strengthen the linkage between the hospitals or the trauma centers and the pre-hospital care. In the West, pre-hospital notification, or PHN as it is called, is a very common thing. The hospital would receive a message about the ETA of the coming in ambulance, and it's pretty natural. But here in India, every hospital, the patients would just turn up on the hospital gate. So we don't have any time to prepare, there's no preparation. So because trauma is a time-dependent disease, every minute is important, so we lose pretty much a lot of time within the hospitals also, because the patients would just turn up. Then embedding the plans of mass casualties. And most of the EMS services, even the 108 ambulance services, do not have HAZMAT, which is hazardous material protocols, or the EMS or MCI protocols therein. That's it. And then finally, I think we need some council or authority, something like TRAI with a teeth, who can audit and also govern these private players who are providing services, because not only do they provide social service, a societal service, but they're also responsible for it to the government. And for that, we need a comprehensive legislation. I think that's the bottom line. Unless we have a legislation, I think the only state to have a legislation is Gujarat. It was way back in about 10-15 years back that they formulated the EMS legislation. Till that, after that, no other state has done that. So we need to shift from just a safe transport to a robust continuity of care. And how do you maintain this continuity of care? You need to be a part of a system to dovetail that pre-hospital care into the in-hospital care, which provides not only the in-hospital acute care, which is in the emergency departments, but also beyond that. So there's a lot of things going beyond the emergency care also, which these patients might need, both urgently, emergently, or after some time. So trauma center concept comes in, which is nothing but a dedicated hospital for acute and definite care of the injured patients. So it does not only provide care, but also coordinate and monitors this continuum of care. So trauma center is just not responsible for just the in-hospital care. Probably trauma centers should be the hub, of also auditing the pre-hospital, which is coming in, and what is going out, the rehab part.
Dr. Gupta.
Yeah, I'll just probably, because trauma team I was asked to talk about the trauma team. So how do we do it? So trauma center is nothing but a normal hospital, probably caring for the injured, but it's an organizational concept. It's not structural. So you cannot just build up trauma centers and say they are trauma centers. You need to have that particular system within the hospital. And in terms of infrastructure, manpower, and also processes. So processes are very important. Our trauma center is actually divided into acute care, and then the definitive care, the two arms, and also the physiotherapy part. So this is how we triage into red, yellow, and green, which is the basic. And we also have architectural triage. So our emergency room, red area is separate from the yellow area, from the green area, so that these patients who are less injured do not contaminate the areas where the really sick patients are in. And that's how we equip them, that's how we man them, and that's how we treat the patients. I think I'll leave on to that. Thank you.
Thank you. Our next speaker is Dr. H.S.Chabbra. He is the Chief of Spine Services and Medical Director at Indian Spinal Injury Center at New Delhi.
Thank you. want to start by thanking Dr. Geetam Tiwari, Dr. Mathew, Varghese, and the organizers for giving me the opportunity to be presenting in this very prestigious institute and very prestigious symposium. I'm also happy because my son has been a student at this prestigious institution in computer science. So I'm very privileged. Thank you for the opportunity. I don't know, how many of you understand what actually spinal cord injury is? Please raise your hands. Very few, right? So this will be generally the composition of my talk. Not a very high incidence, right? But it mainly afflicts the young people, and it leaves them paralyzed below the neck or the torso. And generally, if it is a complete injury, they remain paralyzed for life. So it is recognized as one of the most devastating ailments. And if you look into the lifetime economic burden, it is substantial. Various socioeconomic, political, ethnic, and cultural factors lead to poor availability of spine care as a whole in underdeveloped regions. As such, it was described as an ailment not to be treated till the Second World War, when two stalwarts revolutionized the management. But in India, it took a back seat only till the last 2 decades, 3 decades, that work has been ongoing in this regard. And we also did a study where we could find out that the vast majority of the people cannot afford the treatment and do not get proper treatment. So many developed countries have set up a robust spine healthcare system, including pre-hospital care, and we can learn from their experience, but we need to indigenize it to Indian circumstances to be able to provide proper care. I would want you to focus attention on this very important slide, right? We may not have individual interventions, appropriate evidence on their value in preventing the morbidity and mortality in spinal cord injuries or trauma. But look at these statistics from the US. From the 1970s, before they started emergency care, including pre-hospital care, to the 1986, the mortality rate dropped from 33% to 4.2%. And friends, these are statistics from the National Institute on Disability and Rehabilitation Research, which coordinates works of all the model spinal cord injury rehabilitation centers in US, 21. At one point of time, we were one of the model centers when we engaged in research. Complete injury, people remain paralyzed for life. Incomplete, they may recover. So the incidence of complete injuries reduced from 62% to 21%. From the 1970s to 1986. And that is the impact what proper pre-hospital care can have. In fact, I may not be wrong in saying if one component of spinal cord injury management, it's a very vast gamut, has the most impact in influencing the outcome, it is pre-hospital care. We have simultaneously published various studies on the demographics, on challenges in spinal cord injury management, and neglected traumatic spinal cord injuries. In our study, only 3% of the patients got evacuated by experts to the hospital. And that may be, whatever interventions, that may only depict where we are with pre-hospital care in our country. And it brought out that the main reason for neglect was inadequate awareness, inadequate education, and illiteracy. Not only amongst the general public, but also amongst professionals. So my talk will be more about principles of pre-hospital care in spinal cord injury management. I will be continuously referring to the International Spinal Cord Society's textbook on spinal cord injury management, and on eLearn. It's a wonderful web resource on spinal cord injury management. elearnsci.org, anybody can log on for free and have comprehensive information about spinal cord injury management. So, a potential cause of secondary injuries through inadvertent manipulation of the spinal cord injury. Mark you, a potential cause. And minimizing the chances of secondary injury can be challenging in pre-hospital setting due to the local and transport environment, lack of resources and heterogeneity in healthcare providers and their skill sets. So, again, there are studies which point out that proper handling needs to be done during pre-hospital care, and there are still a lot of missed injuries across the globe which can affect outcomes. Again, the reason for early mortality is airway compromise, respiratory failure, or uncontrolled hemorrhage. And if we can control them by a good pre-hospital care or by training lay responders, it may improve outcome. And how soon do patients reach the hospital? In the developed countries, you can see within 12 hours or even earlier, that was the mean time, right? But little is known regarding emergency medical services systems of low and middle income countries. We don't have proper demographics, epidemiological studies. Our study pointed out on 1200 plus patients that more than 25.5% reached the definitive institution after 1 month of the injury. So that is what is the statistics. And there's tremendous variation in how care is administered prior to arrival in the hospital and during transport from one hospital to another. So it may vary from no organization to basic life support, non-invasive scoop and run, to advanced life support, where there are technicians, IVs and medications, to advanced life support with doctor, right? Basic life support should be rampantly available following successful established models of other countries, right? The injured must survive to make it to the hospital. For this, in a country like India especially, we need a combined approach with involvement of community. And community skills for basic first aid competence is important. So what should the first person at the site of trauma take into, what steps should he take? Take charge, call for help. There should be a proper team which should be evacuating. Check for hazards, number of victims, identify nature and cause of injury, identify as first aider and obtain consent, document actions and protect evidence. Now, unfortunately, we may not have expert or proper trained personnel which may reach there, but if we are able to train first responders, for example, one of the things could be, when you go for a license, you should be trained to be a first responder. And especially commercial, this has been done in Ghana with successful outcomes, as we will show. Protect the injured spine, right? So that further trauma doesn't take place. And unfortunately, this is how transportation of spinal cord injured takes place. So the spine is hanging like this, something that should never happen, right? So the Ghana curriculum, they initially studied that difference in mortality secondary to road traffic accidents between Seattle, where it was 21%, to 51%, which was there in Ghana. They started training professional drivers with a special curriculum. I'll jump the gun, right? Uganda, they had similar results. There are pre-hospital trauma life support. I'll just take 1 minute more, which is there. There are courses which are there, which train them. In a standardized pre-hospital care, all personnel would be trained in it. There should be, it is not only transportation, how the person is extricated from the site of accident, how the spine is immobilized, which devices to apply, how to maintain airway and transport, how to transport, all these are important components. And then where should you take them first? Should you take them to the nearest hospital? But if available, also to the nearest definitive hospital. So in ISCOS, we are grading the various spinal cord injury units and suggesting that there should be a network of such centers so that there can be ideal outcome. And it is also trying to maintain the temperature in the trauma patients, right? So there are simple information sheets, checklists available. We can train first aiders, right? These have been shown, and okay, there are 4 questions which are very important in evidence. What kind of immobilization to be done? How should the patients be transported? What should be used to transport them? And which kinds of population you can actually implement them. In the interest of time, I'll not go there, but all this is available. And I think I have overshot my time. Take-home message from me. The most important component of spinal cord injury management. Believe me, there are around 18, 19 components, which has the maximum impact on the outcome of a person who may survive or not, who may be completely paralyzed through life, or may be able to regain this, is pre-hospital care. Are we giving due attention? That is the question.
Our next speaker is Dr. Sumit Sural, who is the Director Professor at the Department of Orthopedics and in charge of Spine Clinic at the Maulana Azad Medical College and Lok Nayak Hospital.
So, very good evening, dignitaries on the dais and off the dais, and ladies and gentlemen. At the outset, I would like to thank the organizers, particularly Dr. Mathew Varghese, for inviting me to share a little bit of data which my previous speakers have already talked about, but the actual what is happening in 2022, 2020, 2021, 22, a little bit of data from our hospital. That's what I'm going to share today. So there are two studies which I'm sharing. So two studies I'm sharing I'm from Maulana Azad Medical College, and our hospital is the Lok Nayak Hospital, which is the biggest Delhi government hospital and associated trauma center, Shushu Trauma Center. So the first study was to see the spectrum of musculoskeletal injuries, and we did a interview of 50 patients and their attendants of road traffic crashes, both motorists and pedestrians. And our focus was mainly on morbidity, because we have a lot of studies on mortality, but it is what is the morbidity, the economic outcome we have not measured. But to look at the morbidity, we have taken only those patients who had fractures and dislocations seen on X-rays, on radiographs. So they were open or closed. So we have excluded only the soft tissue injuries and the head injuries and chest injuries which were not admitted to our department. So we missed certain injuries like this injury which came to one of the government hospital 2 weeks back. The iron rod penetrating inside very precariously, just fortunately missing the neurovascular structures. So we are just dealing with the fractures and dislocations, not soft tissue injuries. So the mean age was around 36 years, majority were males. Most of the victims were roadside vendors. There's something wrong with this anyway. Roadside vendors, shopkeepers, housewives, a lot of drivers, whether auto rickshaw drivers, cycle rickshaw, e-rickshaws, cars, buses, trucks, and then a whole lot of other occupation. So the drivers were the most commonly injured, followed by the occupants of the vehicles, and the pedestrians were injured around 18%. One of them even got a fracture from a bullock cart. The two-wheelers were the most commonly used vehicle, and where the drivers, occupants were injured. And among the two-wheelers, the most common injured persons were the drivers, followed by the occupants. Especially there was a lot of, more than 2 people sitting on the two-wheelers. And when we studied the pattern of the musculoskeletal injuries, we found that the maximum injuries took place in the lower limb and the knee. And all of them, that is not working, yeah. So all of them were in the two-wheelers, the maximum 34%, and then the three-wheelers. And those injuries around the upper limb and the elbow were also in the two-wheelers. Those who had head and neck and shoulder and back injuries, 80% of them were not wearing helmets or seat belts. And we had a gamut of other body parts which are injured. Many of these victims were either, they were overspeeding or they were without helmets. The traffic light violations were there, vehicular overcrowding, influence of alcohol, absence of driving license, distractions while walking or, using headphones and loud music or watching their cell phones, and others like somebody falling down from a moving bus or somebody's clothes getting entangled in the wheels of a vehicle. All these were different types of modes of injury. Open injuries are very serious. because there are wounds associated, and again, overspeeding, traffic light violations, alcohol, absence of safety gear, driving incompetence, there were vehicular overcrowding, all these were there. Among the lower limb injuries, the maximum were because of the two-wheelers, and they were because of this yellow portion, if you see at the top, that was the overspeeding, and also, again, driving incompetence, people who didn't have license. And there were the gray zone on the top is also vehicular overcrowding, two-wheelers with fractures of the lower limb, and use of alcohol. Absence of helmets and safety belts was seen across not only the head and neck, but all other injuries. Fortunately, they did not get head and neck injuries. So among the crashes, the various factors that the people in the questionnaires, they answered that they were either driving in roads which had problems like potholes and rainwater puddles, or two-way roads without separation, and there was poor street lighting. Even in the daytime, sometimes during the thunderstorm, then kacha and kacha pakka roads, narrow roads with encroachments, poor vehicle maintenance, nearby construction work, downhill terrain down the flyover. Then even there was injuries due to stray dogs coming into the, suddenly jumping into the street. Among the patient transportation, a lot has been talked about by the previous speakers, but the fact was that only 18% came in ambulance. And the others were either auto rickshaws and private cars, police vans, and among those being brought to the hospital, majority, 62% were by the bystanders, rest by the police and some of the friends and family. This is the other study which we just, this was my thesis given to my postgraduate student, which just submitted to the Delhi University. And this was 80 cases. Again, both these studies were during this period, a little bit of the pandemic area, so the number of cases were less during that time. So this map shows our hospital and patients coming from all across many parts of northern India, including 1,700 kilometers away in Bihar, and also from Madhya Pradesh, coming to Loknayak and Shushu Trauma Center. And this is the distribution of, so we are here, bottom is the IIT, and the, so somewhere there, here is the Loknayak Hospital, and further north, that is the Shushu Trauma Center. And by and large, only 28% patients came directly to our hospital. Mostly they came to trauma center, and the ones coming to our hospital were from other government, Delhi government hospitals and other private hospitals. The patients could not afford treatment and being referred to our hospital. Again, the mean age, young people, 32 years the mean age. Again, mostly males.
We should just wrap it up.
Yeah, just. Yeah. So mostly were lumbar fractures, surprisingly, including fall from height was the most common cause of spine injury, rather than the road traffic accident, as was shown by the previous speaker. The majority had some sort of neurological involvement. Asia A means the American Spinal Cord Injury Association. A means complete neurological deficit in 30%, more than 30%. And 8 people had a change in neurology. Well, I don't have time to show what was how these people change of neurology with the transportation, etc. But overall, majority, again, only 10% came by CATS ambulance and 10 other private ambulances, rest majority coming by cars and three-wheelers. And 85% no spine embolization. And in inter-hospital transfer also, patients coming by auto rickshaws from one hospital to another, right? And even in inter-hospital transfer, there was no spine immobilization, right? So around 76% patients arrived before 4 hours, and inter-hospital also usually within 12 hours. So just to summarize, young males and mostly road vendors were in the musculoskeletal fractures and dislocations, drivers, two-wheelers, lower limb injuries and knee injuries due to overspeeding, traffic light violation, driving incompetency, alcohol, road conditions and street lights. Only 18% came by ambulance, mostly by bystanders. And spine injuries, again, young males, fall from height, neurological deficit in more than 50%, deterioration in 10%, no immobilization in 85%, ambulance only 20%, and inter-hospital transfer also taking place till now, sometimes by auto rickshaw and without immobilization. And mostly, that's a good thing, arriving before 4 hours. Yeah, thank you so much.
Thank you, Dr. Sural.
Thank you so much, Amit, Dr. Chabbra and Sumit. You would notice a spectrum that was shown. Amit showed a diversity in ambulances and transportation, what is happening in the hospital. Dr. Chabbra focused on spinal cord injured patients, how they are coming, how there's a need for protecting the spine. Sumit presented raw data and he told me, I'm not going to analyze it, you analyze it while it is shown. Thank you, Sumit, for that. Can I start with Sumit's presentation? The first part was data gathered by a medical student. And the question that is asked from medical students to the patient depends on how the data is gathered, gives you what information you will gather. If it is a questioning of a police or a relative, the police are trained to identify a person who's done a mistake and therefore it is a rash and negligent overspeeding. So in most police reports, you will get the standard report, cause of crash, cause of injury is as overspeeding. So you have to be very careful with this because it is most often speed is the common denominator, but don't take it as a given. We need to analyze that further. That's the first part. The second part is the other reasons, all those is the average common understanding that these are causes of problems which lead to injuries. But they need not be. So we need to understand each of them very carefully. So a hospital-based investigation gives you an understanding, yes, but don't jump to conclusions for preventing steps based on those understandings. So that's an important learning. But the other side that you showed on clearly spinal cord injury patients, both Dr. Chabbra and both of you, prevention of secondary injuries. So when you actually have a spine injury, preventing a secondary injury becomes very critical. So it may not be a problem in a place which is an evolved, mature trauma system, but in an evolving system where patients are moved from one center to the other to the third, that becomes an issue, a secondary transfer. So most of your patients were secondary transfers. So if you saw the 18% ambulance is actually a high percentage. So many of those 18% would have been from one trauma center, social trauma center to your hospital also. So there needs to be an understanding on that. So that becomes an issue. So we need to look at that. Why is it important? Because if you look at the patient transfer, 97% of patients in high income countries are transported in ambulances. Whereas, exactly as Amit showed, less than 5% in a country like India is being transported in ambulance. So we need to understand how do we deal with this. Do we wait our systems to get mature? And in that process of maturation, how do we save and protect our patients? That becomes a critical issue. So how do we protect? We have an ambulance system, as Amit mentioned, uncoordinated. So it is not truly coordinated. There are so many players in the field. How do you get them together? That's an important aspect that you have to take care. So I'll comment on each of these further down. First question is, can we save all the patients? The answer is no. We cannot save all the patients. The commonest denominator for death is head injury, and the next common denominator is hemorrhage. And the first presentation that you heard, actually it should have come later, but we had to prepone it because he had to go for a meeting. So it's important to understand hemorrhage is a very common denominator, but most patients with serious head injuries die on the road. And as Sumit and Amit mentioned about helmets Helmets, motorized two-wheelers were the most common ones. That's very, very common. You've heard for the last 2 days. Motorized two-wheelers are a vulnerable population. And if you have helmets, no helmets being there, again, you can look at how many of them were pillion riders, how many were the actual riders, and how many got the serious injury. So getting the correct information becomes critical here. So you cannot say most of these patients with serious head injuries which happen to have death on the street there. But how can we maximize this patients? I have not seen Haddon's matrix being shown. You heard Bill Haddon's name, but Haddon's matrix has 9 cells. Time and space analysis, pre-crash, crash and post-crash, and human, what you can do there, products, what you can do there, and environment, what you can do there. When we are, as doctors and trauma surgeons, we are looking at only one cell among the 9 cells. One cell, and that is post-crash, specifically in our settings, the hospital-based care. The pre-hospital is still in a nascent evolutionary stage. So that is why when we talk about injury prevention programs in a meeting like this, if you talk of only one cell, we will make a minuscule of difference. We need to work at all the other 8 cells also. That's an important thing that we need to understand. Access is an issue. Amit flagged the lack of a universal access number. Many years back, the ICMR and all of us were taken to the CDC Atlanta. Professor Dinesh Mohan was also there, and there was a news item which came up exactly at the timing with the visit there, training and evolution of trauma care and how we can change things here. The announcement came in the newspaper, universal access number. So I went online, tried to see what happened. Is there any report on that? When I went online, this is what I see. There is a consultation paper on this. The Telephone Regulatory Authority of India. Let me tell you, this is one of the simplest things to be done with today's technology. Your phones can be forwarded to any number anywhere. You can do that. So even if every state is health is a state subject in India, every state can change it the way you want it, but we can actually flag it to whichever number you want to. But this is what is there. There has been a consultation. There is the detail. They say go to this site and get the details. When I went to the site, page not found. This is yesterday. I went on the site, it said page not found. Announcement was made, everything was done. Feasible, internationally it's there, 911, everybody knows from Hollywood movies, but it's not there. So that's an important aspect. Access is an important aspect. Golden hour is critical for serious injuries. But if many of the injuries are just lower limb injuries with just fractures, they can go by any transport without worrying. And in fact, the study that two studies, both from All India Institute of Medical Sciences, done by my friends, before Amit was there, I think. One showed ambulance transportation was 4%, study in 1989, subsequently 2004, 3% shifting. Majority were taxis, were auto rickshaws, and police control room vehicles. So how do we train these people in getting them transported safely, especially you're worried about spinal cord injury patients? He asked about how many of you know about spinal cord injury. That's very important because a spinal cord injury patient survival in a high income country is as high as over 90%. 2-year survival, I'm not talking about immediate survival. 2-year survival is 90%, more than 90%. In India, more than 90% would have had some renal problem and they wouldn't survive 2 years. That's why what they highlighted, Sumit and Dr. Chabbra, becomes important. But speed is highlighted all over. What about sirens and flashing lights? Mean saving time in a study with sirens and flashing lights and overemphasis on speed, trip saved, 50 consecutive trips you save 43 seconds. Every second counts, yes, but in very critical injuries. But most injuries, majority. And for every death that you have on the street, you have about 30 serious injuries, 80 minor injuries. So you're talking about 30 of the serious injuries, and of how many of them would make a difference is 43 seconds. Why is this important? Speed should not be overemphasized. what Dr. Amit showed, a crowded street with ambulance trapped in between. That's a common scene. Your development leads to that only. Then what also you do, you have higher incidence of ambulance crashes being described. So if that is there, you need to be very careful. That's a slide. That's an ambulance. That's last week. There are many like this, and if you go online in the net, you will find several such cases reported in literature, and that is where the review of ambulance speeding has come up. So while you need to have protection, while you need to have care, you need to be careful with the overspeeding of ambulances, and you emphasize so much about seat belting. How many of the patients are in harnesses in their stretchers? Nobody is harnessed. And even if you have a belt like that, it's not going to work. If it is speed like that, they'll go like torpedoes to the back of the driver, and they'll get killed with that crash. So it's important for us to recognize that. And even in the ABC of care, the ABC has been redone now. You don't have to do, airway is important, patent airway, maintaining it by extension of the neck and all, but cardiopulmonary resuscitation, just the chest compression is sufficient in an emergency situation. This is important. So one important denominator I mentioned is bleeding. In the field setting, IV fluid insertion by emergency care healthcare providers is highlighted. But let's look at the physiology. Bleeding leads to lowered blood pressure. Lowered blood pressure is essential for clot to retain there. And that seals off, and then compensatory mechanisms bring up. If you don't control that, blood circulates in a closed system. Supposing you have an injury, a closed system becomes an open system. And to this open system, you fill in fluids. What will happen? The open system will keep leaking till all your blood is drained out and nothing is left. So in critical injury, why don't you see this in the common setting? In the critical injury patient, major vessels are damaged. If you give large volume fluid, you will have problem. Usually studies have shown before the patient reaches the hospital, only 500 ml is given. Less than 500 is given. But major studies have shown it is beneficial to delay this fluid resuscitation. So you don't have to worry. So in the field setting, if you're having a hospital transportation system, you don't have to worry about fluids. That's what the science is showing. You worry about bleeding with tranexamic acid, worry about care of the spinal cord, that will help. So ATLS protocol, Advanced Trauma Life Support Protocol,
Mathew,
balance resuscitation. One slide and I'm done.
Okay.
Medication, tranexamic acid, you already heard about it. So the bottom line is just showing improvement there is not work. We need to have improvement in the hospital also. Otherwise, you'll only shift death from roadside to bedside. Thank you.
Thank you. So we have time for one or two questions, and then.
Good evening, everyone. Actually, I would like to know that do we have any, because being a disabled, it's very difficult to bear trauma, and it happens so often that we have to go through this. So any government or private hospital has any plan, anything, accessible trauma care which has been made. It can be made because I have learned, and I have been, I did not know, I could not think that medical can be made so accessible to disabled from Dr. Mathew Varghese. So it can be made. I would like to know anybody has made it.
I think Dr. Tanu can conclude with the answer to that question.
Sure, I will. So thank you very much for this question. We do understand there are issues, but most of the hospitals now in India, including the central government hospital, AIIMS and the bigger medical colleges, are developing disabled friendly places. And those infrastructures and all kind of disabled friendly equipments are available in the hospitals. Of course, we have issues with overcrowding and overpopulation in the hospitals, but most of the systems are in place, and there is a continuous effort from the side of the government to keep on doing that. Thank you very much for that question.
I'm sorry if this was addressed in one of the sessions. I had to step out briefly. I just wanted to get your opinion about Good Samaritan laws and their effectiveness.
That also, that's a very interesting question because we didn't talk about that. You would like to
see, technically it's a very, very useful thing for bystanders to transport patients, especially why was the law required? The law was required because a lot of hue and cry that people that are transporting these victims, do-gooders, are facing a lot of harassment at the casualty and emergency medical rooms. And therefore this is required, and it is a very useful thing, and you can, if those of people who know about it, they can really argue with the emergency system that is trying to harass you, and the policemen. Those that do not know, they still get harassed. I have faced it myself. I have carried a victim who was unconscious to the hospital, and then the policeman at the gate, they're always there at the gate, asked me, "Kahan se leke aaye ho? Kisko maar ke laaye ho?" So it took a little time for him to understand, and I explained to him that I'm a doctor, I'm a do-gooder. And then I said, I know the law also. As far as, so awareness of this law becomes an important part. Good Samaritan law in the books, in the court, is not just sufficient.
I just would want to add to that, because within all societies working in the field of trauma and spinal injuries, so we were a bit concerned that, okay, you are rewarding the person for getting the patient to the hospital, but are you training the person to be able to evacuate the person properly? So we have written to the minister, Honorable Minister, and he has taken note of it, all the 9 societies, I think, where we have suggested this is a very good act, but we will appreciate if you can also come out with something to train the first responders so that they are well equipped to be able to evacuate them properly, so that there is no secondary injury and you can take control of a lot of things while on the road. So hopefully that will also come.
I'll just add one comment here. You mentioned about the Ghana training of commercial drivers. Yeah. The training was done using a book prepared by me and Professor Mohan. It is available here in the TRIP lab. So they borrowed the first aid manual from us, and they used that manual to train the drivers there.
Just one thing that I want to add before all this. I want to ask you all, how many of you have heard of the Good Samaritan guidelines? All of you? Okay, so that's great. So if you see an accident, what do? Anyone who's wanting to ask a question, can you please tell, what do you do if you see an accident? Which number do you call? Anybody can tell me a number?
This is the selection bias of population.
Oh yes,
they are all
definitely.
Evolved people.
All evolved people. That's why I'm asking. Which number? 112. 112, right? Or 108? 112. How many say 112? Just 2. And 108? 102? 1033? Okay, so this is the most evolved group that we have over here, and if the knowledge deficiency is here, then we can really, not really challenge the government to do it, because if you can go through all these curriculums and all these thick books and all the fancy jargon, then at least these are the basic things we should know. So there is something lacking. And regarding the Good Samaritan, I remember in 2015, when I had recently joined the program. The problem with post-crash response is also, and pre-hospital care is also, that we get the last slot and we do not get sufficient time, and the government comes the last. So, and the government is also answerable to the questions, but nobody will let them say what we have done. So there are challenges, there are issues, it's a big country, and we don't say that we are doing the best thing, but we are doing a lot. So the space should be given for the government to at least say what we have done. So Dr. Chabbra very nicely pointed out, but in 2015, when these Good Samaritan guidelines were issued, we realized that with these guidelines, we are creating a problem. And now people will be encouraged, and rather than they wait for the ambulance, they will rush and take the Good Samaritan to the hospital. And this we have also come to know, because there are certain people, I mean, after a year or two, there were certain states which said, okay, we'll pay you 2,000 or 10,000 if you bring a person to the hospital. Now that becomes an incentive, and you don't want to wait for the ambulance to come. So we already initiated this type of course, but Government of India cannot do everything. So obviously we have rolled out this course is available, and this course is already underway, and societies like what Dr. Chabbra is doing, or Dr. Amit is doing, Dr. Mathew is doing. So a lot of the states are also doing these courses. Actually, this course should be established in schools. All across the world, the schools first aid training is done. And when we go to the hospitals, we realize even the ward boys, even the attendants who are standing in front of the emergency don't know these first aid training. So the problems we have, a lot we have highlighted, we do understand, and there's a list of it. But the solutions, we need to now discuss and deliberate on the solutions more than the problems. So what can we do as societies? What can we do as government? What can we do as institutions? I think that is what me and Amit were discussing, that we are all aware of this. And I had a lot of points, but I think we should give a chance to the audience to ask. So there were a few questions. If 1 or 2 points are there, no, I will, but I want to take the questions first because we've been speaking so much, let them interact. I want that to be a little interactive. Yeah.
If I may ask a question?
Sure.
So we've been speaking about training, pre-hospital training. But in the previous lectures, we've heard from Dr. Mathew that a lot of psychomotor skills are involved in pre-hospital care. And since in most LMICs, the people are being brought by different modes of transport, how can we handle such training which requires repeated skills and accessing those skills? And one more question to Dr. Amit. You mentioned a lot on the failure of PPP models and a lot of operational issues that we've been facing in emergency response. But then are we exploring alternatives? Because emergency response are day-to-day operations. So are we exploring what kind of operational?
No, I think there's no need to discover alternatives. So the land ambulances services in India right now are the only services which we can provide. The only thing is that fine-tune them, audit them. See, what I was highlighting was that they're not being audited properly. Not even by the government, which is employing them on a tender basis or whatever XYZ. True audit is not there, and because there is no legislation, they're doing whatever they want, wherever they want. So all we need to do is that enter into that audit cycle, audit them both structurally. So half the ambulances, even in CATS, you go and see today, you do a structural audit, they will not be competent enough to even transport a sort of light injured patient, leave aside a critically injured patient. So all we need is that maybe they run everything they do, but they should be guided by proper audit systems. That's all. I think that's the keyword. And why ma'am, why this so-called the really elite people are still confused about pre-hospital care number? Because we have created that confusion from the side. You already enumerated 5 numbers in Delhi, which are all there, but finally the people call 100. I'm telling you, I did a survey way back 10 years back. 5 major places like Connaught Place and and the people responded 100. So they would call 100 for anything. So that's why you see 60% of all the injured patients from the roadside are being brought by the police.
Yeah.
So
just to quantify on that, now the number is 112, and as Dr. Matthews also said that this number, even if you dial 108, it will go transfer to 112. If you dial 102, and this is the number that has been created by Ministry of Home, and this number is existing, but you can try and dial it. Sometimes it works, sometimes it takes a little time, but I have done that, so it does respond to you. Even if you dial 108, it will transfer you to 112. So that is the current universal helpline number, so there shouldn't be a confusion. The 1033 number that we see on the highways is the NHAI number, which we had discontinued. Dr. Geetam would remember that we had asked, it got discontinued, but there was a lot of confusion. People were not able to reach because 102 ambulances, the National Highway Authority has a call center, and they were not getting connected to the 102, 108. So they restarted 1033. And what ambulance, Dr. Sumit had shown that 18% ambulance, I think, inter-facility transfer as well as the COVID time. So there were no bystanders or vehicles on the road. So the ambulance really kicked in. Because that was a surprise to us, 18%. No, that's really not the picture in the country right now.
Hi, this is mostly a comment/observation. Dr. Amit, you said a lot of people directly dial 100, right? And we have a lot of people getting the patient, a lot of police vans, I'm assuming these are PCR vans, which are getting the the patient to the hospital. Is it not a good idea to start training the police guys, or maybe have like a primary, a small trauma care guy with the police guy, and So things like you talked about tranexamic acid being a very easily deployable drug, right? All that, can it be stored with the police guys? Because they might have a higher reach, and they are usually earlier on the scene.
Giving them tranexamic acid is a food for thought, but as far as the training is concerned, at that time our center only, and along with 3 or 4 more centers, when 2010 Commonwealth Game was being held, more than 2,500 PCR personnel were trained. Repeatedly, police sends their PCR personnel, because these are on rotation, to our center and maybe to other centers also, for this kind of training. A list of 8 essential equipments at the time of Commonwealth Games was given to the PCR. They did buy them, including a scoop stretcher or something like a stretcher, a cervical collar, and they were trained into it, and some bandages and splints, some very basic things. So training issues, yes, if Delhi police sends, now it's not a proactive thing. Now they have to send their PCR people, we are ready to train. But yes, training issues, whether or not to give them tranexamic acid, I think it will require a lot of, I think because...
Just one small comment here. I think, okay, the traffic policeman or the first responder reaches there, but how do they know that they need to reach, right? So that is what is a crucial thing, information about a crash or an accident happening. And I think sitting at Indian Institute of Technology, we should get the answers here. The latest iPhone 14, even if there is no connection, you press the emergency button, information will reach there. So why do we need to wait for an iPhone 14? Why can't Indian Institute of Technology develop something? Each individual in the country has a mobile. Just press the emergency button, information reaches straight, whether it's the police or the first responder who has to reach there. So I think we have to have a long-term and a short-term strategy in a country like India. It will take a long time before an ambulance can reach every crash victim, right? But we need to have some strategy for training first responders who can take immediate effect. And why not make it mandatory for all people getting a license, especially commercial licenses, to be trained? Right.
Okay, since you asked us all if we remembered a bunch of numbers, and some of them were increasingly devious and increasingly arbitrary, I've just named my house Wi-Fi system by giving the kind of names that you don't have to know what my password is or some funny thing. You just know that this room says Peggy, so it's my room. Study, that's study. Now, why can't we, instead of making people memorize or file the most devious numbers for essential services, have a simpler system where the most obvious number you could think of would be that one number? Because that's easier than, say, training the police to do what, in fact, you want an ambulance to do. If the minute you can ask a question like, which of these 4 numbers is the correct one, I think the problem's at the other end. You've done something very devious.
Okay, thank you for that question. So let me tell you, these numbers are not new. So the ambulance system in the country has evolved over a period of time, and these numbers were not always available. So when the systems were evolving in the states also, the 102 number was for the maternal and child health. So there are different ambulances catering to the maternal and child health. 108 number was for the emergency care. And since these numbers were creating confusion, that's why the thought of one universal helpline number. So what I wanted to tell you was that 112 is the universal helpline number that has been, now for the country, and anyone who's calling on the old numbers, if they don't remember the new number, the call automatically gets transfers to 112. So nobody has to remember the old numbers. But since they are so deep rooted in the system for years and years together, most of the people remember those numbers. And no, that's all right. Like, there must have been some issues. This was the Ministry of Home who came up with the number, which seemed most plausible and feasible. There may have been many things. But like 911 is the number we use in US. So 112 is the number for India. So that is what I was trying to say. Thank you.
one quick question from our side. Actually, trauma management is, as of we all know, that right time and right place. As Professor Varghese told, shifting patient from roadside to bedside for the death. That is the issue. So basically, when we receive patient, the main issue with patient is for the long transportation and the time is that the finance of the patient. Because in urban trauma is a different situation. In rural trauma, that is the facility is too distant. So before some time we got a news that government is doing something like some financial assistance for initial 48 hours. Is that exist or some work is going on that? Because this is serious concern. Maximum patient travel for more than 300, 400 kilometers just for finance. They can got that treatment by nearby, but they don't have so much of money due to involvement of polytrauma and multiple departments.
Nobody can deny treatment to a trauma victim. First aid needs to be given. If the hospital doesn't, they are liable to be sent to jail. And this has happened in the country of Delhi, in the city of Delhi. So nobody can be denied first aid anywhere in India. Am I right, ma'am? So you don't need to travel a lot. The first thing is reach the nearest healthcare facility and then let them decide where to transfer.
Sir, I'll just give a brief overview of that. MORTH had a problem of bringing in or roping in private clinics, especially along the highways. You would go from Delhi to Jaipur, you'll see at least 5 hospitals branding themselves as trauma centers. And these are very, good places where initial care can be given. So this was in 2017 or 16 or 17 when the government tried this pilot project of the cashless treatment in the initial 24 hours of the patient, 48 hours, I think. And a sum of around between 25 and 30,000 rupees was there. So if a private hospital was giving care to any patient for the initial 24 to 48 hours, they would get that money, no questions asked. That was successful, and I think right now the Niti Aayog is very seriously thinking about implementing this particular microinsurance plan. The funds, I don't know from where they'll come, because the initial project, the ICICI Lombard was the private company associated with the government and MORTH. But nonetheless, this is one thing which is happening, and Niti Aayog is seriously thinking about implementing it throughout India.
Thank you.
Many of the states have done it already. So this is, as I told you, that health is a state subject. So government, so many of the states have already done it. In many states it is there.